Hello, and welcome to the webinar, Understanding Lynch Syndrome. I'm Maggie Nicholas Alexander, the Share Senior Director of Gynecologic Cancer, Patient Support, and Education.
And I'm Kitty Silverman, Uterine Cancer Program Director at Share.
Please share in the chat where you're joining us from today. Before the presentation begins, I'd like to tell you a little bit about Share. Share is a national nonprofit that supports, educates, and empowers anyone who has been diagnosed with women's cancers and provides outreach to the general public about signs and symptoms, because no one should have to face breast, ovarian, uterine, cervical, or metastatic breast cancer alone. For more information about upcoming webinars, support groups, and our helplines, please visit our website at sharecancersupport.org. Today's webinar is in partnership with FORCE. Through their programs, FORCE serves people with or at high risk for hereditary cancers. Their community includes people with Lynch syndrome, or an inherited mutation in BRCA1 or 2, ATM, PALB2, CHEK2, P10, or other genes linked to cancer.
I'd just like to go over a few housekeeping items. All participants will be muted during the presentation. Once Heather finishes presenting, we'll begin the Q&A discussion. Please ask any questions for our presenter via the Q&A section at the bottom of your screen. Remember that Heather is unable to give specific medical advice, so please keep your questions general in nature. We also have closed captioning available. You can enable this feature by clicking the live transcript button on the bottom of the screen and selecting the subtitle option. The webinar is being recorded and will be available on the Share website soon. Now I'd like to pass it over to Heather to introduce herself and provide her presentation.
Hi, everyone. It is a real pleasure to be here today. My name is Heather Hampel, and I'm a cancer genetic counselor by training. I have been a cancer genetic counselor actually since 1997. I started my career at Memorial Sloan Kettering, then worked for 24 years at The Ohio State University. And a lot of the data I'm going to share today is actually from work I did there. But for the past year, I've actually been at City of Hope National Cancer Institute or Center and in Duarte, California. And there I am the Associate Director of the Division of Clinical Cancer Genomics and a professor in the Department of Medical Oncology and Therapeutics Research. I also happen to be the Secretary Treasurer of the National Society of Genetic Counselors this year, but I'm rolling off in a few days when 2022 ends. So really happy to be here today and to give you this talk on understanding Lynch syndrome. So I'm going to share my slides now. Okay, here we go. My email is at the bottom of the screen and my Twitter handle. So if anybody's still tweeting since Elon Musk took over, feel free to tag me. And if you have any questions afterwards that we don't get to cover, that you're welcome to email me. All right, so I do have a few disclosures. I'm on the scientific advisory boards for Invitae Genetics, Genome Medical, Promega, and Natera. I do consulting for 23andMe and GI On Demand. And because of the scientific advisory board or the consulting, I didn't buy these, but I got stocks or stock options in Genome Medical and GI On Demand. But none of those will affect the content of my talk today. So the outline of what I want to go through is just Lynch syndrome in general, a little bit about what it is, what the cancer risks are, what the management is, and how frequent it is, because it's much more common than people think. Then I'm going to tell you about a couple studies that we did at Ohio State on Lynch syndrome for populations of colon and endometrial cancer patients. And obviously the endometrial cancer data is most relevant to this group. And end with some highlights about from one of the studies about cascade testing within families, because if you happen to be from a family with Lynch syndrome, you probably know firsthand that one of our biggest challenges is once we identify a family with Lynch syndrome, getting all of the at-risk family members to get genetic counseling and testing has been challenging. And that's a problem because, of course, our goal is to try and keep people from getting cancers by diagnosing them before they get cancer, when we can put into place intensive surveillance and prevention options. So Lynch syndrome. We now believe about 1 out of every 279 individuals has Lynch syndrome, making it about the second most common hereditary cancer syndrome in the world, second only to hereditary breast and ovarian cancer syndrome due to BRCA1 and BRCA2, which you've probably heard a lot about. If you divide the population of the US by 279, that means there are actually 1.2 million people with Lynch syndrome in the US alone. So it's an inherited condition that runs in families and causes high risk for colorectal, endometrial, ovarian, gastric, and multiple other cancers. But a lot of these cancers are fairly preventable. Certainly colon and endometrial cancers are very preventable if we do early and more frequent colonoscopies and through risk reducing hysterectomy. And so knowing that you have Lynch syndrome gives you an opportunity to intervene to keep from getting cancer in the first place, which, for some hereditary cancer syndromes, we can't prevent all the cancers. And then certainly there are cancers that aren't as preventable in Lynch syndrome, but the main two are. And so what's the problem? We currently estimate that 95% of these 1.2 million people with Lynch syndrome in the United States are not aware of their diagnosis. So they have no idea. They may find out when they get a cancer. That's a hard way to find out, or they may not find out at all. And so what I've spent most of the last 20 years of my career working on is how to close this gap and get more of these individuals diagnosed so that they can benefit from intensive surveillance and prevention methods. So I always like when I talk about cancer genetics to tell you what I tell a patient if I'm diagnosing them with Lynch syndrome. So this is a picture of the 46 chromosomes in a male. And you can see we have 26 pairs of chromosomes, one from each parent. So you get one chromosome number one from mom and one from dad, and they come in pairs. What you can't see when you look at the picture of the chromosomes are the genes because they're too small. But we think from the Human Genome Project that there's about 20,000 genes strung along these 46 chromosomes. And again, they come in pairs with you getting one copy of each gene from mom and one copy of each gene from dad. So you have pairs of genes on your pairs of chromosomes, and each gene produces one protein that your body needs to grow and develop properly. So I like to say the mix of these 20,000 genes is the recipe for you. And it's determining things like hair color and eye color. But as we're starting to learn, it's also determining things like predispositions to certain diseases. And I always tell people who have a predisposition to cancer in their family, other families have predispositions to diabetes, Alzheimer's, other health conditions. We're all predisposed to something. We've just come a lot farther in finding some of the genes that can cause cancer to run in families so that we can actually be a little bit helpful in finding out who has those gene changes that put them at risk for getting cancer, and so that we can do something about it. So the way most of the cancer susceptibility genes work is that they are good genes, and we all have them and we want them to be working. Specifically with Lynch syndrome, the genes are what I like to call the spell checkers in your body. So they're involved in DNA repair. And you can imagine that if you've got billions of cells in your body, every time a cell divides, it has to copy all of those 20,000 genes exactly to make a new cell. And mistakes happen. It's a normal part of the aging process. If we stuck a piece of paper in a copier and tried to make 20,000 copies, a few would come out messed up. But we have built-in spell checker genes, our Lynch syndrome genes, who recognize if a mistake gets made when we're copying all of that DNA to make a new cell, and they fix it. So just like when you're typing an email or a text and your spell checker is coming along and fixing typos without you even having to think about it, this is what's happening in your body as your cells are dividing and copying all of this DNA. Mistakes happen, and your Lynch syndrome genes or spell checkers are fixing it. So these are good genes. Everybody has them, and we want them to be working. So what happens in Lynch syndrome? If you look at the right side of the screen, this is a depiction of what happens in Lynch syndrome. So somebody inherits from their mom or their dad one copy of one of their spell checkers that does not work properly. Their other copy from their other parent, sorry, I'm disappearing my hands, works just fine. So that working copy is actually going to compensate for many years and the repairs will get made. And this is why we don't typically see a lot of childhood cancers with Lynch syndrome, because for many years, their one working copy's in there compensating, the spell checking is happening, and everything goes along fine. The trouble is the odds are high with billions of cells in our body that one day over the years, when a cell's dividing, it might acquire a mistake just naturally in the working repair gene or the working spell checker. So now you've got a cell, say it's in the uterus, an endometrial cell, say it's in the colon, it's a colon cell, that has no more working spell checker. Now, that cell doesn't instantly become cancer, but it cannot repair mistakes that happen naturally as the cell divides. So it's going to start accumulating mistakes. And when one cell accumulates enough mistakes sort of in the right places, it will start growing too fast, not die when it should, and that cell will become a cancer. So basically, people with Lynch syndrome are born one step closer to getting cancer because of having that one spell checker not working in every cell of their body from their day they're born. And all it takes is for their second working copy to stop working for that cell to start accumulating mistakes and eventually become a cancer. This is why there are certain characteristics that we see in hereditary families and in Lynch syndrome families that are red flags that the family might have a hereditary cancer syndrome. So one is going to be earlier ages of diagnosis. Because people are born one step closer, it doesn't take as long on average. And so we'll tend to see earlier ages of diagnosis of the cancer, which we generally say are anything under age 50. Now, this doesn't mean a 90-year-old can't get a cancer and get diagnosed with Lynch syndrome. It just means on average, if you look at families with Lynch syndrome, they're going to have younger diagnoses. And it would certainly be a red flag if you were diagnosed at a young age. Multiple generations with cancer. And so here, this family tree drawing, you've got a grandma who's affected, an aunt who's affected. I should have had the father be affected, and then this daughter. And so you have 3 generations of people with cancer. And often I like to say it's also a vertical transmission pattern where you can see it getting passed down through the generations. That's more concerning to me than having a horizontal clustering where maybe a few siblings have a cancer. In dominant cancer susceptibility syndromes, you generally see them getting passed down vertically through the generations, and that's a big red flag. And it's not going to be on both sides of the family, right? It's going to be on one or the other. So the other side will typically not have a lot of cancers. People in the family will tend to have more than one cancer or impaired organs. They might have bilateral cancers. And the reason for that is that if every cell has one non-working copy, you can certainly get a second mistake one year and have a uterine or endometrial cancer. 6 years later, this can happen in the colon, and we've got a new primary colon cancer. And so it's much more likely for people with hereditary cancer susceptibilities to get multiple cancer primaries during their lifetime. So I'm not talking about metastases or spread from the first cancer. You know, if a colon cancer spreads to the liver, that's still one cancer that spread. I'm talking about whole new unrelated cancers. And when somebody has 2 or more of those, that's a big red flag that they might have a hereditary cancer syndrome. And then clustering of certain cancers in the family. I think we've done a good job in the media of getting the word out that breast and ovarian cancer go together in families. I think we've done a pretty terrible job of getting the word out that colorectal and endometrial cancer run together in families. And I think, in fact, most people would not put those 2 together and might, in fact, have a family history of sort of a dad with colon cancer and a sister with uterine cancer and not even think, wow, that they could be connected. And so we've got a long way to go to getting more sort of, even in the medical field, information out there about Lynch syndrome because it is so common and it can be easily missed. And so this is just those 2 chromosomes, the one with the mutation that the person's born with. If you hear people talk about germline genetic testing, those are mutations you're born with. They came in your egg or your sperm, the germ cells. So that's where that comes from. It doesn't stand for an infection, which everyone's like, why is it called germs? Germline means it came from a germ cell, which is an egg or a sperm. So you inherited it. Somatic mutations are mutations that happen in your body while you're aging, and those you're not born with and you can't pass on to your children. And so that second hit, as we call it, that causes the cell to have no more working spell checker is somatic or acquired. And then that cell will accumulate mistakes and become a cancer. Now, again, we say about, and you'll see more detail later, maybe 3 to 4% of colon and endometrial cancers are due to Lynch syndrome, and probably 10 to 15% of colon and uterine cancers are hereditary. So the rest are a combination of sporadic cancers, which just pop up by chance alone, or sometimes we'll also say there may be some familial clusters, which might be due to minor genes that haven't been discovered yet, and shared environmental risk factors in families that might make one family more likely to get cancer than the next, but not one single strong gene running in the family and causing it. So for purely sporadic, you tend to see one person with cancer, not a long family history of cancer. Later ages of diagnosis, sort of average or later. Single tumors, not bilateral or multiple primaries, and again, no family history. And in these cases, people aren't born with any inherited mutations in their cancer susceptibility genes, but we're aging, we're getting exposed to things in the environment that are carcinogenic, and mutations occur. And probably the cell dies and nothing comes of it and there's no problem. But maybe it lives long enough that it gets another mistake and another. And this is overly simplified because it's multiple errors that have to occur. But eventually that cell will also start growing funny, not die when it should, and become a cancer. But these are all mutations that were acquired during that person's lifetime, cannot be passed on to their children. So these are the mutations people look for when they get tumor sequencing these days. So if you are diagnosed and maybe you have a later stage cancer, it's pretty typical for these days for your oncologist to offer tumor testing, where we actually sequence the tumor and look for mutations. They're looking for these acquired mutations that they could target maybe with actionable therapies. When you're doing germline testing to look for mutations you were born with that you inherited from your mom or your dad in every cell of your body, we tend to do, you tend to see a genetic counselor. It's not ordered typically by your oncologist, although some exceptions. And that usually uses blood or saliva sample, not the tumor itself. Okay. So that's just kind of my general overview about how Lynch syndrome works, and here's how it's inherited. So now if you've got a mom or a dad who has one of these non-working spell checker genes, so back to, I wish my hand wasn't disappearing, my charades I'm doing for you, we've got that copy that doesn't work. In every cell of the body, we've got a copy that does work. So this is going to be the same in that person's eggs and sperm. So when they go to have children, it's going to be a 50-50 chance with each pregnancy that they're either going to pass along their non-working copy of the spell checker. That child will inherit Lynch syndrome, will have the increased risk for cancer, and can then pass them on to their future children. But just as likely, 50-50, they can pass on their working copy of their spell checker gene or their Lynch syndrome gene. And in this case, the individual would have no increased risk for cancer at all, despite the family history, can follow general guidelines from the American Cancer Society, and they cannot pass it on to their children. It won't skip generations. So if somebody doesn't inherit the mutation that's running in their family and causing the Lynch syndrome, they can't pass it on to their children. So this is very powerful information. And it, when I was first starting to do cancer genetics, sometimes my patients would be disappointed when they tested negative. And I didn't understand it because they said, well, no, this is better. Your cancer is not hereditary. But only if it is hereditary and we find a mutation, are we in a situation where we can tell people definitively either, yes, your child has inherited this and does have the increased risk and needs to do X, Y, and Z to keep from getting cancer or to catch it early, or no, they didn't. So a black and white answer is sometimes helpful. And also it gives them a reason why they got cancer in the first place. And so I've grown over the years to understand why sometimes people are disappointed, especially if they have a strong family history and they're looking for a reason why sometimes people are disappointed if they test negative. And again, these people who have the mutation will be able to pass it on to their future children with that same 50-50 risk. These people who did not inherit the mutation from mom or dad don't have it and can't pass it on. So it's done in that branch of the family. Okay, so if you've got Lynch syndrome, what are your cancer risks? So we've talked about the main two cancers being colon and endometrial. So there are 4 major Lynch syndrome genes. These are all spell checkers and they work together, but 2 of them have much higher cancer risk than the other 2. So you'll see I've combined MLH1 and MSH2 here. They're the higher risk Lynch syndrome genes. And then I've separated out MSH6 and PMS2, which are the lower risk Lynch syndrome genes. And so your cancer risk with Lynch syndrome are different depending on what your underlying gene change is. So which gene is causing it. And so they're the highest with MLH1 and MSH2. So here you see the general public has a 4% lifetime risk for getting colon cancer. People with a gene change or a mutation, or we sometimes call it a pathogenic variant, a non-working copy of MLH1 or MSH2, have a 33 to 61% lifetime risk for getting colon cancer. With MSH6, somewhere between 10 and 44%, so elevated, but not nearly as high. And PMS2, the lowest risk of the Lynch syndrome genes, with an 8.7, just a double to 20, 5-fold increased risk for colorectal cancer. So very, very different risk. And you'll see this reflected in the screening guidelines I'm going to talk to you about in a minute. Endometrial cancer, pretty high actually for all 3 of these genes, MLH1, MSH2, and MSH6. If you look on the high end, we get into the 50% lifetime risk range. Much lower for PMS2, again, with 13 to 26%. And the general public has about a 3% lifetime risk for endometrial cancer. Stomach cancer in the early 1900s was a major component of Lynch syndrome. Diets have changed and it is not as major of a component cancer anymore. The general public has less than a 1% lifetime risk. And at the highest, the risk for stomach cancer with MLH1, MSH2, or MSH6 gene changes is around 8 to 9%. So significantly elevated over the general public, but still quite rare among people with Lynch syndrome. And we just don't have the data for PMS2. And ovarian, since I know we have a lot of people on the webinar who have or are caregivers for people with ovarian cancer, certainly a higher risk with BRCA1 and BRCA2, but we can see pretty elevated risk here. MSH2 in particular really goes up to about a 38% lifetime risk for ovarian cancer, MSH6 up to 13%. And again, PMS2 is so low that it's actually debatable how much, if any, it is increasing the ovarian cancer risk, which again, you'll see a little bit reflected in the screening guidelines I'm going to talk to you about in a minute. And of course, we know the general population's lifetime risk for ovarian cancer in women is 1.3%. So these are the main 4 cancers. There are a number of other cancers that have slightly elevated risk, but they're all sort of more rare cancers in general, and the risk are not as high. And you'll see things like pancreatic cancer. We can see glioblastoma brain tumors. We can see specific types of skin cancers in the sweat glands called sebaceous adenomas or sebaceous carcinomas, bile duct cancers, pancreatic cancers, small bowel cancers. So you can see a lot of other cancers. The full list can be a little bit overwhelming, but we focus on the main for when we think about surveillance. We do think about sometimes with MSH2 in particular in males, there are some urinary tract cancers and the collecting ducts in the kidneys, the ureter and the bladder that we actually do sometimes consider screening for. Okay, so what is the surveillance? So what we typically do, most academic centers in the US follow the NCCN guidelines for surveillance recommendations for people with Lynch and other hereditary cancer syndromes. So the NCCN stands for the National Comprehensive Cancer Network, and it is a group of cancer centers who send experts in the field of cancer genetics, and they make a panel and they review the literature. And the nice thing is that these guidelines are reviewed at least once annually, and sometimes they're updated more than once per year. So they are the most current of any screening guidelines available. And because of that, they do change over time, though. So if you were diagnosed with Lynch syndrome 5 to 10 years ago, you may need to check back in with your provider because the guidelines may have changed. Some places will send a newsletter out so that they can update people about changes in the surveillance guidelines because they do happen so quickly. So the surveillance for colon cancer, here's where you see one of those differences based on the genes. For MLH1 and MSH2, the higher risk genes, we start colonoscopy at age 20 to 25, and we do it every 1 to 2 years. guys. So it's a lot more colonoscopies than someone in the general public who starts at 45 and goes once every 10 years. So someone in the general public might get 3 or 4 during their lifetime, 45, 55, 65, 75. Someone with Lynch syndrome could get, if they started at 20 and did them annually, by the same 75, they could have had 55 colonoscopies. So a lot more colonoscopies. They become quite good at the prep. And we believe most colon cancers start as a polyp. So when you see that polyp in the colonoscopy and snip it out, you've stopped a cancer before it starts. There is some data emerging out of Europe that occasionally some Lynch syndrome cancers can start really straight out of the colon wall without going through the polyp step. And those would be missed by colonoscopy. However, they would be always caught early if you're doing it every 1 to 2 years. With MSH6 and PMS2, is still colonoscopy every 1 to 2 years, but because of the later onset and the lower risk, we don't start it till age 30 to 35. So it starts a little bit later. And for both of these, there is a caveat that if there's a really young colon cancer in the family, we're going to start the screening 2 to 5 years before that youngest diagnosis. So I have an MLH1 family who had a 19-year-old with a stage 3 colon cancer, and we are starting that family's colonoscopies, people who test positive, at 14, which is 5 years prior to 19, just to err on the side of caution because we have seen a very early colon cancer in that family. So endometrial cancer, there is some evidence that if people get sort of blind rappel biopsies of their endometrial lining every 1 to 2 years, starting in their 30s, at age 30 to 35, we can catch endometrial cancers early. The trouble is there's actually no data that it actually improves outcomes because people tend to get diagnosed early with endometrial cancers from having some abnormal bleeding between cycles or after menopause. So while it can catch endometrial cancers early, it may not lead to a longer lifespan because they will do well even if they get diagnosed based on symptoms typically. But there is screening available and some people choose to do that. Other people lean towards a hysterectomy. And because of the ovarian cancer risk, which we'll talk about next, for which we don't have good screening, as many of you know, many people just consider once they're done with childbearing, closer to a natural menopause, doing a hysterectomy and removing both ovaries and fallopian tubes or a bilateral salpingo-oophorectomy to essentially eliminate the risk for endometrial and ovarian cancer. With BRCA1 and BRCA2, you see a pretty significant remaining risk for cancer in the abdomen, of primary peritoneal cancer that looks and acts like ovarian cancer after the ovaries are removed. That seems to be quite rare in Lynch syndrome. It can happen, it's been reported, but it's quite rare. So a hysterectomy and BSO, or removal of both ovaries and fallopian tubes, seems to be very effective in almost eliminating the risk of endometrial and ovarian cancer for people with Lynch syndrome. So with ovarian cancer, you know, their transvaginal ultrasound and CA-125 blood tests are what people try to use to screen for this cancer, but there have been many studies looking at it, and it catches some early and invariably some slip through to stage 3. And so we don't trust this screening, but people can do it if they want to try screening instead of surgery. They, again, also after childbearing, and closer to natural menopause, may just consider the surgery. Now, here is a situation where if you read carefully in the NCCN guidelines, for PMS2, they word it much more softly, the BSO, the ovary removal, because that risk, as you guys saw on the last slide, was maybe not even increased. And it's, you know, a major surgery with big effects on your life. And so that one, you know, the wording is much more soft about a consideration, not a recommendation. So the stomach, small bowel cancers, do an upper GI endoscopy every 2 to 4 years, starting at age 40. And presumably if they see anything there, they can take a little biopsy and hopefully catch anything early. But as I mentioned, these cancers are much less common in Lynch syndrome families in the US today than they were in the early 1900s. The urinary tract cancers, again, not a lot of evidence to support this, but in families that have a history of it, or particularly males with MSH2 mutations, we do recommend annual urinalysis, so checking the urine sample for blood, starting at age 30 to 35. And that's non-invasive to give a urine sample, so most people do it. not a lot of evidence that it's going to catch things early or change outcomes. Pancreatic cancer, if there is a pancreatic cancer in a close relative in a family with Lynch syndrome, and that family member did have Lynch syndrome, we do recommend pancreatic cancer screening beginning at age 50 or 10 years younger than the earliest diagnosis in the family. We'll have people do annual contrast MRI or MRCP, or sometimes alternating with an endoscopic ultrasound. And if they see something they're not liking, they might do it on closer intervals, just to keep an eye on things and look if the things they're seeing are changing or staying stable. The trouble with that screening is people get a lot of cysts on their pancreas, and most of them aren't going to cause a problem. And you have this dilemma about, do we need to biopsy this or not? And so it can be anxiety provoking and can lead to a lot of unnecessary biopsies as well. Prostate cancer risk is probably elevated in men with MSH2 mutations, but it doesn't seem younger than average. So we just follow general population screening, but some people don't get prostate screening anymore. And we would recommend men with MSH2 mutations in particular definitely get prostate cancer screening, PSA blood test, and a digital rectal exam. Breast cancer risk has been very controversial, whether it does or does not exist in Lynch syndrome. The reason for the controversy is that there are not more cases of Lynch syndrome when you count them in families with Lynch syndrome than you would expect to see by chance alone. However, if you look at the breast cancers, half of them have evidence they were actually caused by the Lynch syndrome. And so it's sort of this, doesn't really make sense. When half of them are due to the Lynch syndrome, why are we not seeing more overall? So at this point, we just recommend general population screening for breast cancer. For the brain cancers, they're not a great screening, but they say when you get your physical once a year, make sure the doc does a neurologic exam. And then, of course, we talk to anybody with a hereditary syndrome about their options for prenatal diagnosis or pre-implantation genetic testing if they would like to not pass the mutation on to their future children. And we always tell people that if they have Lynch syndrome and haven't done childbearing yet, they may want to have their partner tested for Lynch syndrome as well, because if two people with Lynch syndrome in the same gene have children together, the children could inherit two non-working spell checkers, and that's really bad. It causes a condition called constitutional mismatch repair deficiency, and we see childhood hematologic malignancies, childhood brain tumors, and then in their teens, they actually start getting the adult Lynch syndrome cancer. So it's a much more severe condition. And so we just like to let people know, if you have Lynch syndrome and you know this in your 20s before you have kids, you may want to have your partner tested before childbearing. Other ways to prevent cancer. So there's some good evidence that taking aspirin daily, if you have Lynch syndrome, will reduce the risk for colon cancer. Early studies look like it might reduce the risk for endometrial cancer as well, but now we've got 20-year follow-up and it looks like it pretty much specifically reduces the risk for colon cancer. Something about the anti-inflammatory properties seems to be why. So this is known in the general population, and I think they just walked this back, but for a short while, the U.S. Preventive Services Task Force recommended a baby aspirin a day for adults age 50 to 59 to prevent colon cancer risk and cardiovascular cancer risk. And there have been a study in patients with Lynch syndrome using much more aspirin, 600 milligrams a day, that did show that the risk for colon cancer was reduced by 63%. So the question is a baby aspirin enough? One adult aspirin, which is 325 milligrams in the US, or two adult aspirin, which would be 650 milligrams in the US, which is quite a bit and more than they even used in the study. So there is a CAP3 study underway in Europe right now that's going to determine optimal dose. So how much do we need to take, and optimal duration? How long do you need to take it? But this study was 2 years of daily use, and you started to see the benefits at 4 years. Not 4 years of use, but 4 years after they started, and they had to take it daily for at least 2 years. So more on this to come. Most people are having US patients do a baby aspirin daily or one adult aspirin, and it kind of depends. Oncologists who treat the cancers usually go for the larger adult aspirin. GI gastroenterologists who treat GI bleeds from aspirin tend to go with the baby aspirin and be a little more conservative. So that's why we don't know the answer to that. Family history used to be how we diagnose Lynch syndrome. And if you have a family history like this, it's pretty obvious, right? They've got 3 generations, multiple people with colon and endometrial cancer, people diagnosed under age 50. I mean, if somebody didn't recognize and refer this family, I would think there was something very, very wrong. But not all the families look like this. And particularly with the MSH6 and PMS2, the lower risk genes, they can have a very mild family history that would not meet traditional criteria. And also, we've just found people don't take the time to take a family history. They don't know the criteria. And so it's just not the best way of getting patients diagnosed. I think that's why only 5% of people with Lynch syndrome are aware of their diagnosis. We just haven't been very effective at getting people diagnosed historically. So what I've worked on over the past 20 years is better ways to get people diagnosed. And one of the ways is to focus on a couple of the genetic features of Lynch syndrome that are very unique. And you can actually screen for them in the path. I'm going to sneeze. Excuse me. You can screen for them in the pathology department at the time of diagnosis and identify patients with colorectal or endometrial cancer or ovarian or other cancers who are more likely to have Lynch syndrome so that they can get sent to genetics for genetic counseling and genetic testing. And so this is a way of kind of not worrying about age of diagnosis or family history, but screening everyone to see who is more likely to have Lynch syndrome. So these genes, as I mentioned, are spell checker genes. So we call them DNA mismatch repair genes is their fancy name. But when they aren't working properly because they can't make repairs, that leads to a characteristic in tumors called microsatellite instability. For those of you with cancer who probably have been following immunotherapy, it turns out that microsatellite instability is a really important biomarker in tumors now. Since 2015, when they discovered that patients with microsatellite unstable tumors respond very well to immune checkpoint blockade therapy, which is very, very exciting for my patients with Lynch syndrome. And we have seen remarkable stories of patients with stage 4 cancer who were going to hospice, who got on immune checkpoint blockade therapy and are 6-7 years out, no evidence of disease. So knowing if you have microsatellite instability is an important thing, especially if you're a stage 3 or 4 cancer patient who's going to need treatment. But what we used it for originally was to see who had microsatellite instability, because people with microsatellite instability are much more likely to have Lynch syndrome. They don't all, but they're much more likely. And only 15% of colorectal patients have microsatellite instability. Almost 30% of endometrial cancers have microsatellite instability, so it's kind of a lot. And ovarian, there hasn't been a study like this, but I don't think it's nearly as high as it is with endometrial cancer. And so you can this is a harder test, doing microsatellite instability. You have to actually extract DNA from the tumor. And what they do is they look at 5 different microsatellites, which are just areas in your DNA where there's repeats. So our DNA is made of 4-letter code, A's, T's, C's, and G's. And so one of the famous microsatellites that we look at is a microsatellite called BAT26. And BAT26 is just a spot in your DNA where there's 26 A's in a row. So it's literally A, 26 times. When your DNA is trying to replicate 26 A's, it's very common for it to slip and miss a few. Maybe it only gets 20 of the 26 because it loses track. That's just A. It's complicated. So if your spell checkers are working, they'll recognize that mistake has happened and they'll fix it, and you stay at 26. If your spell checkers aren't working, you can't recognize that mistake happened and fix it, and you now have 20 A's in your tumor instead of 26. So they literally just measure these little repeats and see if they're the same in your tumor as you were born with, or if they typically shrink. They could expand, but they typically shrink. If they've shrinked and they're a different size, those repeats in your tumor than what you were born with, that's considered instability. And the minimal to check is 5 of these microsatellites. And if 2 or more have instability, the tumor is considered microsatellite unstable. It's more difficult for small community hospitals to do this test because it does involve DNA extraction. But if you're getting tumor sequencing, as we talked about a couple slides ago, it's generally included these days, and they may look at many, many more than 5 of those repeats. The more common thing to do is this immunohistochemistry test. So that's a big word that just means you can cut thin slices of a person's tumor and stain them with an antibody to the 4 mismatch repair or spell checker proteins. If the protein is present, you'll see nice brown spots in the nuclei of the cells, like you do here for MSH2 and MSH6. If you've lost both copies of your spell checker in the tumor, you will not see nice brown staining like you don't see here. See how it's just blue? in MLH1 and PMS2. And you might be saying, but Heather, I see some brown spots. Those are not the colon cells. Those are normal adjacent tissue. And the reason they still have the mismatch repair gene is, remember, you're only born with one copy not working. The other copy works and is making protein in your normal cells. So they have staining in the normal adjacent, and that's how you know the stain didn't fail. It worked. The normal cells have the protein, but in the tumor who's got the second mistake, there's no more protein being made and it's absent. So this is easier to do. It's less expensive generally. And the pathologist just looks under the microscope. And I've looked at these with our pathologist, and you can see very easily if any of them are missing or absent, and you'll get a report on your pathology report that goes to your doctor. They go in pairs. So these two often are gone together, and these two are often gone together. These two can be gone by themselves, but that tells us actually a little bit about which gene is probably causing the Lynch syndrome in the family. That used to be helpful when we had to test one gene at a time and it was super expensive. Now that we do these big panels, it's sort of not as useful because you're going to test for all the Lynch syndrome genes anyway. But this is what immunohistochemistry looks like. If you had it on your tumor, this is what they looked for. And if any of the proteins are absent, you are likely to have a microsatellite unstable tumor, and you are more likely to have Lynch syndrome, but it is not diagnostic of Lynch syndrome. And again, anyone who's MSI high or has one of these proteins missing, which they'll call defective mismatch repair protein, will benefit from immune therapy. Okay, so switching gears to tell you just a few things we've learned from some of the research studies I did in Ohio, and I may go fast because I want to leave plenty of time for questions. But this was a study that we had open at 50 hospitals in the state of Ohio, and we enrolled every single patient with colon cancer over a 4-year period. We also, only at Ohio State in Columbus, enrolled all of our endometrial cancer patients. I think since this is an endometrial talk, I may just skip the colon cancer data and go straight to the endometrial for you guys. Okay, so here's the endometrial data. So we had 341 endometrial cancer patients. We tested all of their tumors with both microsatellite instability and immunohistochemistry if we could, or one or the other if we couldn't get both, and found that about 27%, so remember I said about 30% of endometrial cancers are microsatellite unstable, so here was 27% had what we would call defective mismatch repair or microsatellite instability. 73% had proficient mismatch repair, which makes them unlikely to have Lynch syndrome. And they sort of are done as far as worrying about Lynch syndrome. So the next thing we do with the people who have defective mismatch repair is the number one cause of this is actually an acquired change in MLH1. As we age, and particularly in women, it's fairly common for the MLH1 gene, which is one of our spell checker genes, to acquire methylation in its promoter. That's my analogy for this is that there's an on-off switch in front of genes, and you want it to be on so it's working, but if it gets methylated, it turns it off and you don't get any of the protein made. So it's sort of not there, and it makes a tumor with microsatellite instability. It looks just like a Lynch syndrome tumor, but this is an acquired thing. Loading that methylation on the on and off switch and turning it off is an acquired thing, more common as we age and more common in women. So we can check for that methylation on the on-off switch in the MLH1 promoter. And literally 76% of the patients with defective mismatch repair have that acquired methylation. So they probably don't have Lynch syndrome. And again, they go to the done pile in terms of, we think it's unlikely they have Lynch syndrome. Could be something else, but not Lynch. So that left out of 341, only 22 patients who had defective mismatch repair and no acquired methylation. So these patients all need gene testing, right? We need to figure out if they have Lynch syndrome. So we do gene testing for all of them. Almost half, 10 of them had Lynch syndrome. So we found mutations mainly in MSH6. It's got a lot of endometrial cancer, 6 of them, 3 in MSH2, 1 PMS2, and no MLH1 in this particular series. And so this means 45.5% of the cases that had defective mismatch repair not caused by acquired methylation are due to Lynch syndrome. If we did not find Lynch syndrome, we actually sequenced their tumors, their actual endometrial tumor, and every single one of those remaining cases, 12 out of 12, had acquired 2 mutations in a spell checker gene in their endometrial cell during their lifetime. So they weren't born with a change, they didn't have Lynch syndrome, but they acquired 2 during their lifetime, and that made the tumor have defective mismatch repair. It looked like it was Lynch syndrome, but it's not. So that's really important news because these patients don't have Lynch syndrome, don't have increased risk for second or third primary cancers, and can't pass it on to their children. Whereas this group does have Lynch syndrome, has increased risk for second and third primary cancers, and can pass it on to their children. So in this group, we do what we call cascade testing, which is we offer testing to all of their at-risk family members and kind of follow the mutation through the family and try and identify everyone who's at risk that we can, so that they can benefit from increased screening. This group does not need the cascade testing. And again, all of these individuals here will benefit from immune therapy, even though only the smaller group, which ended up being 3% of the total, had Lynch syndrome. Okay, so what this means is out of all endometrial cancer patients, 27% have defective mismatch repair and might benefit from immune therapy. 20% overall are due to that acquired methylation, so they don't have Lynch syndrome, and they can't pass it on to their children typically. 3% do have Lynch syndrome, and about 3.5% have acquired mutations in their spell checker during their lifetime. They don't have Lynch syndrome, but their tumor will benefit from immune checkpoint therapy. And if we've ruled out that methylation, it's almost half and half. You just saw it a minute ago. 45% have Lynch, 55% have double somatic. So I think this study is interesting for this group. This was a follow-on study called OPTEC, the Ohio Prevention and Treatment of Endometrial Cancer Study. And we enrolled 963 endometrial cancer patients in this study at 9 hospitals in Ohio from 2017 to 2020. So this is very recent. And we said, well, you know, what are we missing by just screening for Lynch syndrome? What about other hereditary cancer syndromes? Why don't we just gene test all of these patients with endometrial cancer? So we offered them no-cost genetic testing for 47 gene cancer panel called the Common Hereditary Cancer Panels. We also did all the tumor testing just to see what we might have missed had we done that alone. But you know, the real goal was, you know, what percent of endometrial cancer patients are hereditary, and how much are we missing if we just focus on the Lynch syndrome? So this study had 963 patients. 425 were from NCI designated comprehensive cancer centers, so big cancer centers, but more than half were actually at smaller community cancer hospitals. And so we like that we had that good spread. A few patients too were excluded for having the wrong diagnosis, or we weren't able to confirm their diagnosis, leaving 961 who all got germline genetic testing for a panel of 47 cancer genes. So we confirmed yet again our results that 3% of endometrial cancer patients have Lynch syndrome. Remember, the last day was 2.9%. It was 3 on the head here. So 3% of endometrial cancer patients have Lynch syndrome, that's for sure. But here's what you miss if you only look for Lynch syndrome. 7.1% of endometrial cancer patients had a pathogenic variant and a different cancer susceptibility gene. Maybe it was BRCA1, BRCA2. It may or may not have at all caused their endometrial cancer, but it's certainly important because they may have an increased risk for getting cancers, whatever cancers are associated with those genes, and they can pass them on to their children. And then luckily, about 90% or 89.9% of people with endometrial cancer did not have any pathogenic variants in any of the 47 cancer genes that we tested for. And so busy slide, but just to show the interesting thing here, when we test everybody without regard to their tumor, whether their tumor had that microsatellite instability or not, we had the most PMS2 mutations, which was not what we had seen in the other study, if you remember, where we had the most MSH6. MSH6 was second most common here with 10. MSH2 was 6, and still MLH1 quite rare. But this was kind of a surprise that PMS2 moved up so much. I think we had 1 in the other study. Again, it's a third the size, but if you take it times 3, you might expect 3, and we had 11. And so we think that probably, and you'll see in a minute, some of these people had PMS2 mutations and endometrial cancer, but their PMS2 mutation did not cause their endometrial cancer. It was just an incidental finding that they had a PMS2 mutation and an endometrial cancer. So when we tested their tumor, it was microsatellite stable. It did not have abnormal IHC. And that tells us, you know, this was probably not caused by their Lynch syndrome, but they do have Lynch syndrome with the lower risk gene. The features of the patients with Lynch syndrome were very similar to the overall population. So most were early stage endometrioid pathology, except younger age of diagnosis, which we would have predicted, right? We know hereditary ones are more likely to be young. So the average was 55.5 compared to 61.6, and lower BMIs. So we know high BMI or body weight, body mass index holds estrogen and increases our risk for endometrial cancer. And so that's an environmental risk factor. And so in Lynch syndrome, because you're born one step closer and the gene is really causing the Lynch syndrome, you might imagine that people would have lower BMIs. They don't have as much of that environmental risk factor. So the BMI of our patients with Lynch syndrome was on average 29.1 compared to 36.8 in all of the other endometrial cancer patients without Lynch syndrome. But interestingly, when we looked by gene, it looked like PMS2 had higher BMI. So again, more like the general population, another hint that maybe their PMS2 gene wasn't causing their Lynch syndrome. And here's just looking at 10 of the patients with Lynch syndrome, we would not have diagnosed by doing the tumor screen because the Lynch syndrome didn't cause their tumor in this case. And so all of the MLH1 and MSH2s had abnormal IHC. 9 of the 10 MSH6 had abnormal IHC. Only 1 of those would have been missed. So pretty good. The tumor screening would have caught almost all of those. But with PMS2, a lot of the patients, maybe like one of them we couldn't test, but of the 10 remaining, 5 didn't really have absence of PMS2 when we looked. And so again, maybe these were not caused by their PMS2 mutation, but they do have one. And that's just looking at the PMS2. So briefly, cascade testing. Once you've identified that patient with Lynch syndrome, we want to test as many family members as possible. In our study, the first one, the Ohio Colon Cancer Prevention Initiative, we had 132 colon cancer patients we diagnosed and 10 endometrial cancer patients we diagnosed with Lynch syndrome. As you saw, we offered genetic counseling and testing at no cost to all of their at-risk family members and ended up testing 554 relatives, finding another 184 positives. So we doubled the number of positives by offering testing to family members who need intensive surveillance and prevention and may pass it on to their children. And 345 tested negative. And that's great news too, because they can just follow the American Cancer Society guidelines for cancer screening. And so this cascade testing component is really important. And when we were trying to convince people to do MSI or IHC on all colon and endometrial cancer patients, what made it the most cost effective is getting as many at-risk relatives tested of the people you find with Lynch syndrome as possible, because in those individuals, you can keep them from getting cancer in the first place, they live a longer life, and that makes the cost effectiveness much higher. So opportunity, this is, I don't think we have time for this. We just had one family where we did really, really good. We tested 131 relatives in one family. I call it extreme cascade testing, but I'll just give you the drift here. These 2 individuals ended up being sort of 5th cousins, and that's how they had a variant of uncertain significance. We were able to reclassify it as pathogenic because they both had Lynch syndrome cancers and they were related and they had the same mutation. And because of a bunch of genealogy work here, you can see my young genetic counselor colleague gave me this 8.5 by 11 pages taped together version of their pedigree. And we ended up testing lots and lots of people and finding, really 4th and 5th cousins who are at risk and thousands of at-risk relatives. So I think we could do a better job with cascade testing than we've been doing. I have a lot of people to thank. These are the main people I worked with on the study. Rachel Perlman's the genetic counselor I worked with most closely, Dr. Dilla Chappelle, my mentor who passed away 2 years ago before I left OSU. And we collaborated with lots of labs who helped as well, because these were big studies. So I think we'll stop there so we can get some questions answered for you guys. And we'll see if we've got anything. I don't know if there was any questions in the chat.
Great. Thank you so much, Heather. That was a very informative presentation. So let's begin the Q&A. You can still submit questions in the Q&A section at the bottom of your screen. We will try to get through all of the submitted questions, but we may not be able to due to time constraints. So the first question and I think it goes well after what you were just talking about with cascade testing, but at what age do you recommend genetic testing for a child of someone with Lynch syndrome?
Great question. So we typically recommend testing at age 18 or older, but before 20 to 25, if it's an MLH1 or an MSH2 family, because that's when their colonoscopies need to start if they test positive. You have a little longer with MSH6 and PMS2 since the colonoscopies don't start until 30 or 35. So we like to know before someone needs to start screening. So that means we do make exceptions if there's a really young diagnosis in the family, but typically we can wait till 18. And the nice part there is the kid's an adult, they can make the decision for themselves. No one's making the decision for them, right? So it drives parents crazy. I admit it would drive me crazy too. I'd want to know if my kids had it or not, but it is something that, when they can, having a personal choice in the matter is a good thing. And so waiting till they're adult and letting them decide for themselves if they want to do it or not is important. Now, the trouble is 18-year-olds, aren't always thinking about preventive health. It's a time when they're applying to college and there's a lot going on. And so we'll see. I have some kids who literally are engrossed in the family history, know this is going on, have been in, advocacy and running the 5Ks, and they literally will schedule on their birthday, and I'll see them the day they turn 18. And then I have others who they're busy at 18 doing other things with life, and they usually hit me up after college around 22 in time for their colonoscopies to start on time, but no sooner. And so that's when the two peaks. Now, again, that family I mentioned with the young diagnosis, the 19-year-old with colon cancer, because I'm going to start colonoscopies in the positives at 14 in that family, we are recommending that family start their testing at 14. So this is general for adult onset cancer syndromes, the rule. 18 or older, unless there's a particularly young diagnosis in the family, and then you may have to test younger. There are some syndromes that affect children, some polyposis syndromes, and in those we of course test kids. But it's all driven by when the screening would need to change. What age would the screening need to change if they test positive?
Great, thank you.
Thank you. Heather, what's the general recommendation for genetic testing for someone with endometrial cancer? Like they get the diagnosis, what would you do then?
So right now it's rather complicated. There are NCCN guidelines. They should all get tumor screening. So everybody recommends they should have MSI or IHC. And I don't think that is happening everywhere. So I would make sure that gets done. And obviously, if that's abnormal, it's more likely you have Lynch syndrome and you need to go get gene testing. If you're under 50, it's currently recommended all endometrial cancer patients get gene testing. And then if you're 50 or older, you need something else, like either the abnormal IHC or MSI, or maybe another relative or a personal history. Maybe you had endometrial cancer and colon, or you've got endometrial and dad had colon. So you need a little more family history. There are many of us who, based on my data that I just shared with you, showing that 10% test positive, and that you really couldn't predict a lot of the people who tested positive, are moving to the idea that perhaps we should be offering multi-gene panel testing to all endometrial cancer patients. That is not in the recommendations yet. Just this summer, NCCN said you can consider a multi-gene panel test for all colorectal cancer patients based on very similar data. So I would not be surprised to see, if for some reason, working in Lynch syndrome, endometrial seems to lag a few years behind my colon every time I'm trying to get recommendations. I would not be surprised to see within the next 5 years that there's a recommendation that all endometrial cancer patients get offered a full multi-gene panel testing. We'll still keep doing the MSI and the IHC because we need to know for immune therapy, but it won't be the only way we're finding hereditary cancer syndromes.
That's very interesting. Thank you.
Great. And so this person has Lynch syndrome, and they're wondering if there are individual things that they can do to prevent the Lynch syndrome related cancers, such as healthy eating and exercise, or do these environmental factors really not have an impact?
That's a great question. And people, anything you can take control of, you want to take control of when you're in this situation. I used to say, well, if you're looking at a 40 to 60% chance of cancer, something that makes a big dent on a 2 to 4% risk for cancer may not make as big of a dent on a 40 to 60%, but it can help. And there are some studies coming out of Europe, this Lynch study, that do show that being at a healthy weight, exercising, eating a good diet, does make a difference. And but really the only thing right now that you can do besides the screening to lower your risk is the aspirin that I mentioned. And be on the lookout. The hot new thing is that we are going to see in the next year opening up 2 different studies using a vaccine to try and prevent cancer in patients with Lynch syndrome that I'm so excited about. I can't even tell you. I mean, that the idea that we could maybe vaccinate people against their cancer is a game changer. But you know, the earliest people involved will be like the earliest people involved in the COVID vaccine study. So we have people in line waiting for those studies, and other people are like, let me wait and see what happens with that, and then I'll be in the second wave. So that's the most exciting thing. But yeah, your typical healthy things no smoking also. Smoking has been associated with increased colon polyps. So all the good healthy things that work in the general public do help in Lynch syndrome.
Great, thank you.
Heather, this is a very interesting question. Why are all of these genetic mutations grouped into one syndrome?
Yeah, well, the genes work together. I used to have a very neat movie that showed MLH1 and I think MSH2 and 6 recognize the mismatched DNA, and they start clamping on your DNA. And then they pick up an MLH1 and PMS2 that are hooked together, and they sort of unzip the piece of DNA with the spelling error. And then your body comes in and lays down the corrected DNA. So they literally are all 4 working together. 2 of the players appear to be more important than the other 2. That's why they have higher risks. But people are starting to call it MLH1 Lynch syndrome, PMS2 Lynch syndrome, because the cancer risks are so remarkably different. And it's probably true that, you know, in addition to the colonoscopy age start difference, over years, the management will start to diverge more.
Thank you.
So looking at the time, I think we could probably squeeze in one more question. And you sort of started to touch on this, but are there treatment implications for individuals with Lynch syndrome?
Yeah, so yes, the main things are that for the colon cancer, there's pretty good evidence that the standard treatment 5FU is not as effective. So a lot of times oncologists, if you're stage 2 and you're kind of on the fence about whether they're going to give you chemo or not, if they see you've got an MSI high tumor, whether you have Lynch syndrome or not, they will not give you 5FU. And then, of course, for our 3s and 4s, and we're starting to back this up, maybe there's some trials using it in first line setting, they have offered immune checkpoint blockade therapy. So this is your Keytruda, those kind of drugs that help your own body's immune system fight your tumor. They work very, very well in patients with microsatellite unstable tumors. And this is why we always say it's very important to know your biomarkers, because if you don't know you have a microsatellite unstable tumor, you cannot benefit from immune checkpoint blockade, potentially life-saving therapy. As I mentioned, that patient with stage 4 going to hospice, her life was saved. Sometimes I think about my patients with Lynch syndrome who died before immune checkpoint therapy became available in 2015, and how many of them would still be here. But that's just what happens with research in progress, right?
I think we're going to wrap up. Thank you so much, Heather, for a really informative program. And thanks to everyone for participating and submitting questions. Make sure to check out our upcoming educational programs and support groups, and follow us on social media as well. And also, we'd like to ask you to please take a moment to fill out the survey at the end of the webinar. The survey will show up in the browser when the webinar ends, and the link will also be in the follow-up email that you'll get. And all surveys are anonymous. So this concludes our webinar for today. Thank you so much for joining us, and have a good rest of the afternoon.
Thanks, everyone.
Thanks so much.